Assalamu alaikum. So another right radical nephrectomy laparoscopically in a female 52 years of age with a lower polar mass which is totally endophytic and is invading all the lower and middle calyces and also abutting the main renal vein and artery. Here there are little adhesions of the peritoneum to the undersurface of the liver. So those are being cleared. After clearing those adhesions, we'll be applying the liver retraction. So after application of the liver retraction, we are further mobilizing the colon. Here you can see that appendix is also clearly visible. We need to stay away from the appendix because manipulation can lead to inflammation and appendicitis, which may require surgical intervention. So we have to be away from that. So this is adrenal gland. So mobilization of the upper pole peritoneum from the liver gives a little edge to us. So this is the mobilization of the duodenum. You can see the duodenum anterior. We need to stay away, especially with the energy source, away from the duodenum, because slight or even the mildest of heat can lead to thermal injuries to the duodenum, which can show later on. As we all know that the thermal injuries to the gut, they are not immediately visible, and they are diagnosed late, and once diagnosed, the mortality is really high. So prevention is the best thing to do. So avoid using any energy source, be that monopolar, bipolar, or for that matter harmonic, or even a ligashore, Seal device, Thunderbeat. So care must be taken to use them near to the duodenum or any part of the gut. So one thing which is worth mentioning here in this video is the use of a faulty Hem-o-lok clip applicator. As you see, the surgery is really clean. We are able to dissect the hilum in a matter of 10 to 15 minutes. But after that, we took around half an hour extra to control a situation which arose because of the use of a faulty Hem-o-lok clip applicator. So I think so this is the artery, which is superior. This is the tissue around the artery, which I am using bipolar cautery and coagulating it in order to create space all around the artery just for single clip application. So we were lucky that we were able to apply that single clip, and here you can see that clip which is applied, and now you can see that there is no flow in the vein. So this is the dissection of the tissue behind the vein using the 30-degree telescope, which is tilted, so we can see the tissue posterior to the vein. It's a lovely instrument, 30-degree telescope, especially in urology, and this bipolar in your left hand can make your life really easy. So all the tissue has been dissected around the vein. So it's a matter of 5 minutes now just to apply clips. You can see the 10 millimeter right angle. This is the faulty instrument, and I think after this incident, the slippage of the first clip, I should have changed the clip applicator, but somehow I wanted to use it again. So this use of this clip again made a real mess. You can see that the posterior surface of the vein is caught in it, It slipped and I tried again. It slipped and then I tried again. And after that, when I was removing it, there was a hole on the posterior surface of the vein leading to bleed. So principles are the same. You can increase the pressure as the hole was on the posterior surface. So I did not increase the pressure because increasing the pressure can lead to complications. So I used the method of compression. So after 10 minutes of compression, you can see that the hole was sealed because it was a small hole. And now I changed the applicator, and now you can see that we'll be able to control the posterior hook of the hemolog clip needs to be seen. Here you can see that we can see that hook, and that is applied. So we were lucky that the artery was already clipped, so there was not much bleed. But if an instrument is once faulty, it should be removed from the surgical tray. So this was the lesson that I learned, and here you can see that now we have applied 3 clips proximally, and there is retrograde bleed from some vein which tore in the process, and now we are quickly applying clips on the artery just to get rid of the kidney which is containing some blood. So retrograde flow of the blood is now stopped because it was the blood which was present in the kidney, so it is now empty, so there is no blood. And now we dissect the adrenal gland. One can see the adrenal gland very clearly, and we dissect between the parenchyma of the upper pole and the adrenal gland to avoid any further bleed. So the rest of the case is almost the same. Repetition of the same steps, mobilization of the posterior surface, and then mobilization of the lateral surface, which makes it really a 5 minutes procedure. And then we clip the ureter and we complete the procedure. And after cleaning, washing the area, we will place a drain, and then we will come out of the patient. Thank you very much for watching and enjoy the procedure.